Hello, Andrew Colsky here with Therapy BTS, Therapy Behind the Scenes. Today we're going to be talking more about OCD, and we have Nick Zapata, who is a counselor in Virginia, practicing in the area. So, Nick, welcome to the show, and tell us a little bit about yourself.
Hey, Andrew, thanks for having me. So I'm originally from Miami, Florida. That's where I did my undergrad, and then I moved here to Virginia for grad school. And right now I'm a resident in counseling. I'll be hopefully finished in the next couple months. Hopefully by June, I'll be applying for licensure. And yeah, I work with adolescents, young adults, and quite a few kids now. So that's been an interesting change.
Fantastic. So, what school did you go to, and what degrees did you get?
So for undergrad, I studied at FIU and I got my bachelor's in psychology. And up here, I went to Marymount, and that's where I earned my master's in clinical mental health counseling and a master's in forensic and legal psychology.
Fantastic. Congratulations on that.
Thank you.
So, all right. So you said you started with undergrad in psychology. So tell us a little bit about you and your background. What got you into the field in the first place, as opposed to some other discipline?
So I think there are two things that I would credit with starting my interest in just helping people in general. There was a book I read when I was in middle school. Um, it's called A Child Called It, if you're familiar with this one.
No, I,
Um, it's an autobiography that this man wrote about the abuse he experienced when he was a child. And I remember sort of like the hero in the story is the school counselor that he finally confides in about the abuse he's been experiencing at home. And so that sort of piqued my interest in wanting to help someone in his situation or just someone who's struggling with something that others aren't aware of. Um, and then I have an older sister who is a social worker. And I remember being maybe early high school, and she was working on her master's at the time. And I would look through her DSM-4 and just like learn about her classes. And I was very interested in the psychology, material that she was bringing home. And so I think those two, coupled with I took a couple of psychology classes in high school, really solidified that that's the career path I wanted to take.
fantastic, fantastic. So, okay, so you get yourself into school, into a master's program, you
Mhm.
graduate, and how do you figure out what you want to do in terms of areas of practice?
Yeah, so uh, that's a great question. I think it also goes back to sort of that mindset I had when I was a teenager myself. The idea that adolescents are at such a critical point in their lives where future outcomes really depend on the experiences that they have during those teenage years. And so for me, it seemed like the place where I could make the most impact or have the most area for positive change um, was during adolescence. And so that was always my mindset. I think since I was in high school, I knew that the population I wanted to work with was younger people, be able to help them and make changes that could, drastically change the path that their life takes.
Hmm. Great, great. So, so today you're
Mhm.
in a private practice setting, right?
Yes,
Okay.
yes.
And
Uh,
tell us about the types of clients you see and the types of issues that you deal with.
So, as I mentioned at the beginning, I'm working with more kids than I was expecting to. So as young as 7 or 8.
Hmm.
Um, but I do still see a fair amount of teenagers, some young adults, and I'm also working a little bit with some adults in their maybe 40s and 50s. So it's a pretty diverse group, but a majority of them are still in my preferred range of, preteens, teens, and young adults. Um, they present with all sorts of either anxiety, depression, a lot of ADHD cases, some OCD cases as well. I've been fortunate to get a couple of those, but not as much as I was working with in the past.
Great, great. So, okay, so a lot of those things, I think, we hear a lot about people with anxiety and people with depression, and these are pretty well represented types of things that a therapist is going to see. The OCD angle is
Mhm.
something that is unique and different.
Yeah.
A lot of therapists don't practice in the area, and one question that has become a standard question for me on every single podcast when I talk with anybody about OCD is, did you in your classes at school learn anything about OCD?
No, not really. The general, we've gone through the DSM, and so in that sense, we mentioned it as, a related disorder. It's in this field of, anxiety disorders. But no, we didn't receive any, specific training or any specific instruction on how one handles OCD cases. No.
So you've kept my streak alive. The answer is always the same from everybody. And I'm just making the point to the audience that um, for whatever reason, which is a whole different conversation, we don't tend to cover OCD in school for people who are in mental health professions, people who are in psychology degrees, people even psychiatry. If it's covered, it's minimally covered. And
Mhm.
what that means is that when we get out into practice, there are clients who have OCD and they get undiagnosed or misdiagnosed a lot because the person they're seeing, not through no fault of their own, but if you don't have training in OCD and you don't know how to recognize it and you don't know how to treat it, you're going to miss it. And I was guilty of that as well when I started out. I didn't have any training until I eventually learned. Then it's like, oh, wow, that's what that person
Mm.
had.
Right.
So, um, so you are one of the few therapists out there who actually works with OCD. So what got you into it, and why did you stick with it instead of going the other direction?
So, coming out of grad school, I did not expect to work with OCD cases. It wasn't really on my radar. Like I said, since we hadn't really been given much information on it, it wasn't a focus of mine. Um, but while I was finishing, or while I was in my internship, and then for the first 2 years of my residency, the audience may not know, but I was working for you. You were my supervisor when I was an intern, and then my boss once I was a resident. And it was because of the interest that you took in OCD and the trainings that you were going to, that was sort of my real introduction to it was, you would attend a lecture and then share the information, the PowerPoints you would go through, and teach me a lot of these things. And they're still, that's exactly what I'm still using today. I haven't gotten at my new job. I have not gotten any, new training or anything like that on OCD. So it's really based on the information that you shared with me and, the training that you gave me. And those early experiences helped, inform how I approach OCD cases today.
Hmm. Great, great. Well, just for the audience's sake, so I do supervise different interns and residents, and I always expose them to OCD. Many of them, that's not their forte. In other words, they choose not to pick that up, and they have other interests, which is perfectly fine. We need people for all areas, but in your case, then what attracted you to OCD? Why not just do something different?
I think the thing that I find most rewarding and interesting about OCD is that we are making progress that we can actually track. You can quantify it. It's very tangible. Clients get to see their own progress by comparing anxiety scores from last month to this month, or even week to week. Um, being able to give them that feedback and show them their scores and show them the progress that they're making is really rewarding. And it's a lot of fun. It's more hands-on, I think, than um, just standard talk therapy. The fact that we can do an exposure in session is a change of pace, and it's enjoyable for me. Not so much for the clients at times, but it is enjoyable, I think, just for them to be able to see their progress in a way that in talk therapy you're not really putting a number on some of these things that we're working on. So it's a little bit harder to kind of track that progress.
It's interesting that you describe it as, sort of a fun type of thing to do, because there's a lot of therapists out there who I speak to, either, training at a conference I'm speaking at or whatever it may be. And there's this generalized fear that many of them have, which is when they hear that part of the treatment is exposure therapy, exposing the person to the thing, the stimulus that causes them to feel this distress, they feel, the therapist feel,
Mhm.
wow, I feel like I'm harming the client, and I don't want to be doing that. And
Mhm.
I have to explain to them that, well, part of the treatment is they have to be in a um, place where they're exposed, feeling the distress, so they can do the work, so that ultimately they don't feel the distress anymore. They don't have the problems that they're feeling. And, trying to avoid that just leaves them stuck in this perpetual state of distress. But it is that there are many therapists who make the choice that that's not the type of work that they want to do for that reason. And then there's the others, like yourself, like me, like some of the other folks that we know, who can appreciate the fact that you see that progress, and you have someone who may come in on day one and they're very distressed, and I mean, I've had clients that have been dealing with OCD for 50 plus years, and they finally decided to, seek treatment. And I normally say relatively short time, but I'm thinking I'm going to change that to a very short time, meaning in a handful of sessions, they
Yeah.
make remarkable changes. Um, so tell us a little bit about your experience with clients and the changes you see. Are there any particular struggles, or just what's it like to take a new client and get started with therapy?
So, the point about some therapists not wanting to cause the distress or, want to potentially harm the client. Um, I think part of what helps me feel more comfortable and not feel like I'm potentially doing any harm is those first few sessions before the actual exposures start. Um, I really focus on rapport building, making them feel comfortable, making them feel safe in that space where we will be doing things that are scary or uncomfortable. Making them feel the most relaxed possible so that when we do start the exposures, I feel like I've done my part to help reduce any possible harm, even though we know that they're not going to be harmed by doing an exposure anyway. But I want the client to feel more at ease. Um, and so the other part of that, and what you've taught me, as something that I've taken, is the psychoeducation piece. The more we can explain ahead of time, the less scary and intimidating the process becomes. And so I really enjoy those first few sessions as well, even before we actually start the exposures, in teaching them things that they may have lived their whole lives without really understanding. And so by normalizing that, I think that's the first um, part of the maybe it is a few sessions before that they start really making progress. It's by just explaining it so that they have the vocabulary, so that they know the information. um, that's what helps them connect some of their own dots on their own, and I think that's where you have noticed some progress. It's just the client finally understands these things fully. It's not as intimidating, it's not as unknown to them. And so I have found that the beginning part is just as fun as the actual exposures. I don't think that was your question. I'm sorry. What was your question?
No, I mean, basically, we were just sort of talking about what it's like to work with a client and have to,
Mhm.
know that you're eventually going to be
Mm,
exposing them to this stimulus.
yeah,
And, but that's the thing is that it sounds scary, like, oh my gosh,
yeah,
I'm gonna have to be exposed to the thing that causes me this distress, but I'm doing everything I can to avoid it. And the
right,
reality is, well, you're not actually doing everything you can to avoid it. You're just in a loop where it keeps coming back. And
right,
everything you're doing keeps you in that loop. And you're
right.
absolutely right in terms of the psychoeducation piece. When someone can understand, well, this is what's happening, and this is
Hmm.
why it's happening, and this is what we do about it, then, you're bringing it into perspective for them. And that makes them much more ready to do the
Yeah.
work. Um, so,
And breaking it down too, sorry, just breaking it down in that, we have, when we make the scale, we're not doing the number 10 thing, right? Like we're making, baby steps initially. We'll do this one little thing. And so by, putting that in perspective for them that you will eventually be able to do these things. But right now we're just doing this little tiny one, makes it a lot more digestible for them and makes it a lot less scary or intimidating than it would otherwise be.
absolutely, absolutely. So with someone with OCD, and especially if you're talking about younger kids, maybe that are still living at home, they're still in school, uh,
Hmm.
or really any age, people typically have someone or others that they're living with. Maybe it's parents, maybe it's a partner, maybe it's siblings, whatever it may be. Um, have you had to deal with any situations related to family accommodation or others? And tell us about that.
Definitely. Yeah, working with parents and partners, either husbands or, boyfriends. Um, in those cases, yeah, it's the same approach that I would take. I would have them join for a part of the session and kind of give them a little bit of psychoeducation. I've also found a lot of resources. Um, about living with someone that has OCD, and I've shared those as well. Those can be very helpful to just kind of normalize their experience, and provide them a little bit of information as well about what their loved one is dealing with, because a lot of the time they're not a you can see the compulsion side of it, but you have no idea internally what the person is struggling with or what that feels like, or how prevalent it is on a daily basis. So I think just explaining to them this is, the totality of what the disorder involves and what it feels like, what it looks like, is important. And then, sharing with them the role that they play in the cycle, and how by reassuring, depending on what the compulsions are, but usually it's checking, and so it'll be a form of reassurance. Um, how that contributes to the cycle and how that might feel like they're doing the right thing. You don't want to cause your loved one distress, but by reassuring them, you're reinforcing the OCD, and so letting them know that the role that they can play in this process is by um, not feeding into that, by not providing the reassurance. Um, and that can be difficult for everybody, for the parents, for the loved ones. They need to kind of understand it before they can really buy into that, and feel like they're not doing harm. So I think explaining that piece is really important to get their cooperation, because it's
Mhm.
important that they not do those things.
Yeah, yeah, and I'm curious from your experience, does that once you kind of have that conversation and give that explanation, does
Mhm.
that typically help to address the issue, or do you have some people that have a hard time accepting the fact that it's not good for them to accommodate these fears?
I think it's come up more with parents because parents really, they see their child that's distressed, they see, their child is anxious and coming to them for, just reassurance. And so, explaining to parents in as gently a way as possible that, the more often we're doing that, the more we are reinforcing for the child. Um, the same intrusive thought and compulsion cycle. And so it's a conversation I've had a few times with the same parents just to kind of reiterate it. And sometimes we would do check-ins at the beginning of the session, and I would ask the parent, did they check with you? And if so, how did you respond? And so kind of exploring strategies for um, how the parent can respond without providing the reassurance. So, yeah, sometimes it's a conversation we will have a few times before it really becomes part of the process.
Mhm, mhm. Yeah, you're right. It's hard for parents, for partners, for loved ones when
Mhm.
they feel, you mean I have to harm them? And it's like you're not harming them by
Right.
by you know, not engaging in the compulsion, you're not harming them. Do they get more distressed? Yes, they do. But that's part of what treatment is because ultimately they have to learn that that distress that they feel is not the end of the world. They are able to live with it. They are able to cope with it. And when they start going through therapy and all the other parts, that distress goes down anyways. But if we don't engage in the therapeutic process and we hide from it and we try everything we can to avoid it, we just keep that person stuck in a heightened level of distress.
Right. Right.
So,
Absolutely.
so another question that I get a lot from people,
Hmm.
you were talking about certain intrusive thoughts and things like that. So you'll have some people that have obsessions about physical things, contamination obsessions. I'm afraid to touch certain things because it might get dirty and might make me sick. And then you have
Right.
other people that have these intrusive thoughts that are not physical types of concerns, but I'm having this thought that I might do this thing or this other thing might happen. And they ask me, well, isn't that like, I mean, totally different? Or, you're telling me they're both OCD. And so, I always explain to them that, OCD is OCD is OCD. And yes, it
Hmm.
shows in different ways, but the process that's happening in your brain and the way that we address it, yeah, we have different techniques to
Hmm.
address it, but it's still the same treatment. Do you ever get questions like that from clients?
Um, I don't know if I've ever gotten a question. Well, yes, not frequently though, maybe not as frequently as you do. But yeah, I have had clients in the past that will try to um, ask if there's a difference. Or I had one client that was doing a lot of TikTok research. She would watch a lot of videos, which I would explain to her is, contributing to this problem. But she felt like she was getting information that she felt was more accurate, and I was trying to explain that, it is all part of OCD. You don't need a outward compulsion. It's not the stereotypical hand washing or light switch flipping. It has a lot of different forms, and a lot of them are internal. It's just ruminating about things, imagining things, and it's still OCD. It's just, yeah, that rumination is a compulsion, is the point I'm getting at. Yes.
Yeah. Yeah, and that's, with access to the internet, like you said, and TikTok and things like Reddit and Quora,
Hmm.
all
Oh
these
yeah,
different
Reddit
things.
was a big part of that. Hmm.
Yeah. A lot of patients do this checking that you're talking about where they want to reassure themselves about something. And part of OCD, a common phrase you'll hear someone with OCD say is, well, if I could just know for sure that fill in the blank.
Right.
And the point is, you can't know for sure that because
Right.
life is gray. Life is not 100%. And even
Hmm.
if you were to tell them, I can guarantee you absolutely 100% for sure, no doubt X, they'll say, Yeah, but what if, and they'll
Right.
go right back into their loop. So it really
Mhm.
doesn't matter. But they'll spend sometimes hours
Yeah.
researching on the internet. And of course, I'm sure anyone listening to this knows that whatever you look for on the internet, you're going to find. May not
Oh,
be
yeah.
legit, may not be, evidence based, it may not be,
Mhm.
realistic, but you're going to find something. So
Mhm.
if you're predisposed to, believe that the moon is made out of cheese, you're going to find stuff on the internet that shows you that the moon is made out of cheese.
Right.
So that's one of the things we have to deal with in the therapeutic process.
Yes.
So
Unfortunately.
excuse me. So
Mhm.
tell me about do you have any particular um interesting cases or things, or even a case conceptualization that you could walk us through. So, if someone is watching this video and they don't really know what OCD treatment is like or what to expect,
Mhm.
because they hear us talking about this distress and all,
Right.
what does it sort of look like? Someone comes into you and just kind of walk us through what treatment looks like.
Okay, so I'll use a real example of somebody I worked with when I was still an intern, and then finished up with during my residency. So it was I think like a year and a half or so, maybe a little bit longer. Um, but he came in with a couple of different forms of intrusive thoughts and anxieties that he had. Some of them were contamination related, so like touching the Xbox disc
Mhm.
or batteries. He would need to wash his hands, sometimes wash his mouth, and so there was like the contamination side. But then there was also um, I don't even know what category it would cleanly fall into. It was sort of rapid changes. So, like if you're watching, like a werewolf movie, somebody transforming into the werewolf, or in his example was the blueberry scene from Willy Wonka and the Chocolate Factory. So the little girl eats the candy and then she turns into a blueberry. That was very distressing to him. The scene from the movie, just the idea of changing rapidly. Um, and so we took them one at a time. We started with the Xbox disc, well, how in depth do you want me to get? Like making the sud scale and everything, or
Yeah, I
just
mean, because someone who has OCD who's thinking about treatment,
right?
give them enough of a flavor so they can kind of
Gotcha.
understand what it's going to look like.
Okay, and so we uncovered all of those by going through asking all the questions that are part of the first couple of sessions, just getting to understand what are the sorts of intrusive thoughts that they have, what are the sorts of compulsions they engage in, getting a history of those, because over time sometimes you experience something in childhood that isn't necessarily currently an intrusive thought, but just to kind of map out the history of intrusive thoughts, compulsions, how do they show up? And so he had a variety that he dealt with over time. But by the time he came to me, it was sort of those main three that I mentioned.
Mhm,
Um, and so ranking them, what's the most distressful, the least distressful, making the SUD scale. And then even within that, okay, so the Xbox disc was the easiest. That's what we started with. Um, I would have him rank his anxiety if he were touching the disc versus holding the disc versus putting the disc up to his face. And so we created sort of a roadmap for, okay, we're going to start at this place, and this is what the incremental buildup will be. And so the first few sessions was with one finger, the disc was in the box, just touching it, 30 seconds, ranking his anxiety on the scale. His homework would involve that, holding a finger for X amount of time. And then you start building up from one finger to two fingers to putting your whole hand on it to then holding it in your hand to eventually he would just hold it up to his face. And so that became, what we would do in session, what his homework would be, and we would work our way up through the roadmap that we had laid out at the beginning.
mhm.
Then he got to a point where he had no issues. If he had to change the discs, he would change the discs, not have any intrusive thoughts or anxiety related to the contamination from that. So then great, we close that one, we move on to batteries. Start the exact same way. He had the remote control, one finger touching it, then built up to eventually he was putting the batteries in his mouth.
Wow.
So we went from one finger touching to he would pop two batteries in his mouth for 2 minutes at a time. That was his homework.
Wow.
Um, and so done with that, close that chapter, then on to the blueberries. And so that was, I'm trying to think how we started. I think initially it was just watching the scene from the movie, ranking his anxiety. Then it became actually interacting with real blueberries, so holding a cup of blueberries, putting the blueberries in his hand, putting them in his mouth, eating the blueberries, and so working our way up through those as well. So it took a little while. There were a couple of different areas that we were working on, but he made great progress. He responded really well to the treatment. Um, he was really good about the homework. He was very consistent. I think that's in the past where it can be sometimes difficult if the client is so anxiety averse that they don't want to do the homework on their own. I always explain that I can't do the homework for you. Like we can do it in session, but that won't be enough. You need to do the homework. You need to do it on your own. Continue building on it so that by the time the next session comes, we can maybe move on to the next thing.
Mhm.
So progress really is guided by um, the level of commitment and the willingness of the client to be a little bit uncomfortable. Yes, it's not easy, but it's also doable. And so, um, yeah, that's sort of the outline of the treatment with him.
Okay. So tell us, for example, when you had him touching the disc and moving up
Uh-huh.
that hierarchy, roughly how much time did it take to go from step one of using one finger to touching your face? Are we
Ooh.
talking months? Are we talking minutes? Are we talking days?
Not minutes or days, unfortunately. With him, that was our first exposure. We started with the disc.
Mhm.
So I think that one maybe took a little bit longer. It's hard to remember now. This was like 3 or 4 years ago.
Mhm.
Um, Probably a couple of months, I would say, from one finger to disc on his face.
Okay.
Yeah, it was probably a few months for sure.
Okay. And then when he moved on to the other exposures, did those tend to go quicker?
A little bit, yeah. By then, he was already kind of used to managing anxiety, sitting with the discomfort. We also were increasing the number of homeworks, and so he got a little bit more into the rhythm of it. And so we were seeing faster progress in terms of week to week. You could see a significant decrease already. So that made it a little bit faster for the other ones for sure.
Mhm. Mhm. Okay. And I can imagine that, perhaps someone watching this video might be saying to themselves, what's the big deal about touching a disc? I mean, you're putting a finger on a disc. Why does anybody care? But, you know, for someone with OCD, that can be incredibly uh, distressing if
Oh
they
yeah.
have these obsessive doubts related to it. And I
Hmm.
think it's hard for family members and loved ones who don't have OCD to understand what the person with OCD is going through.
Right.
But the distress is real, right? I mean, they're not
Mhm.
just making it up.
Right. Right, and that's again where the psychoeducation for the family is really important because they need to understand how distressing it is. They really need to understand what it's like to live with. I've compared it to like you're trying to do work while there's someone banging a cowbell next to your ear, and it's the just the thoughts are there and they're attacking you, and it makes it very hard to function when you're dealing with them in that moment. And so yeah, it's finding ways to illustrate that to the families, how difficult it can be. Because it like we mentioned earlier, a lot of it happens internally. The intrusive thoughts certainly are internal. So anyone around you may not even know that that's what you're thinking about, that that's what you're dealing with. So yeah, it's about just helping them understand how distressing it can be.
Right. I like the example with the cowbell there. I'm gonna steal that.
Yeah. Good. Yeah,
So
I've borrowed enough from you.
well, so I do this OCD support group, and sometimes we'll have people mention about the fact that, um, well, I've s- gotten these intrusive thoughts, and they're really distressing to me, and I've researched on the internet, and it says that I'm just going to be stuck with this for the rest of my life, and there's no hope, and I'm just going to have to, learn to buckle down and deal with it. And you know, they really come in with just no hope that there's any way to get past
Mm,
this, and that their life has come to this brick wall.
right.
What do you, as someone who treats OCD, what do you have to say to that type of thinking?
I understand where it comes from. I know that, like we had mentioned, you can find anything on the internet to support whatever belief it is that you have, and so that's really again where I provide them information. I can provide them with examples of case studies. I can share, how I just did, examples from my own work of people that I've worked with and the progress that I've seen. Um, so, I do sort of present it to them as what you'll get out of it is again what you put into it. Like the work needs to come from you. It is possible, but we have to one believe that it's possible, and two put in the work to make it possible. Because it's there. It's just a matter of being uncomfortable, being a little bit unsure. But yeah, the change is definitely achievable. It is doable. So that's what I may say to them.
Yeah, yeah, no, I appreciate that. So one other topic that I want to make sure that we cover, which is,
Mhm,
if there were other students like yourself when you were a student, or
mhm.
other therapists who maybe have never dealt with OCD, um, and they, you know, maybe you're thinking about learning a little bit more, what tips do you have for them of how to, like, where to even start, or how could they get more information, like walk them, tell us how can they get started?
Yeah, so there are some great resources online. The International OCD Foundation has been one that's been really good with information, and that's what I've shared with family members of people with OCD. Um, I would encourage people to just learn about the actual treatment, exposure and response prevention, find out what the process is, because some therapists don't like how structured it is, how you have to follow the certain steps and all that. So it won't be for everybody, but if it sounds interesting, learn about what the process actually is, what's involved on the therapist part, and then what's involved for the client. What are they expected to do? But there are some great resources online. You certainly have compiled a great library of resources. Yeah, you yourself are a good resource. But just talk to people in the OCD space. But yeah, just learn about it, see what's required of you as a therapist, and see if it's for you. It is for me. I do like the structure of it. I do like how every session where I know what we're doing, it's following a program, and we get to see that change. Some people don't like how they have to adhere to that, and that's okay.
Mhm.
But for those who do, it's a lot of fun.
Yeah, yeah, great, great. Well, so I appreciate you sharing your experiences with us. And let me ask, so if somebody's watching this podcast and they wanted to get in touch with you to get some treatment, to get some help, to get some advice, how can they find you?
So I think the easiest way to reach me would be via email. It's Nick Zapata, Zapata, at IPA, like the beer, McLean, MCLEAN.com. Nick Zapata at ipamclean.com. And I will, be happy to answer any questions or, connect with somebody for treatment, or refer them to you or somebody else for treatment as well. So that would probably be the easiest way to reach me.
Okay, and you're currently practicing only in Virginia?
Only in Virginia, yeah. Our office is in McLean. I have in-person availability, and then I also see people virtually as well. But right now, only in Virginia.
Great, great. Okay. So then last question for you is if someone is watching this podcast and they feel that they may have OCD or a family member that has OCD and they're
Mhm.
unsure about where to go, what to do, they're uncomfortable with the situation, maybe even a little bit embarrassed that they, have the type of OCD they have.
Mhm.
What's your best advice to people?
My best advice would be, as tempting as it is, don't self-diagnose. Don't go on Reddit. Don't go on TikTok. Don't try to find answers from other people's experiences because everybody's experience is different. And it's not necessarily going to be indicative of what you might be dealing with. So my best advice would be to talk to a doctor, physician, who might refer you, but a therapist is going to be able to give you um, the answers. But I would also, recommend seeking out specifically somebody who works with OCD. Like we talked about, a lot of therapists are not specialized in it or don't have training, don't have experience with it, and may give you incorrect information. So the place where I would go for that is um, I would search on Psychology Today for a therapist that works with OCD. I mentioned the IOCDF has referrals and people in their network that they can connect you to, and so seek out somebody who specifically works with OCD, and ask about what you're dealing with. There's nothing that anybody is dealing with that no one's ever heard of. There's nothing unique to anybody that has, not been treated already. So as strange or unique, like the blueberry thing, it could be anything. We don't control what our intrusive thoughts are. And so whatever the thing is, I'm sure people have worked with somebody similar, dealing with something similar to you. And so just reach out, ask for help, get connected with somebody who knows about OCD is the most important thing, I would say.
Yeah, I appreciate that. And I think I lied about the last question because now here's my last question.
Uh-huh.
So I appreciate the advice you shared there. And one thing that I find important for people to know is that because OCD is so highly specialized and because for whatever reason we don't really teach it in school,
Mhm.
um, I always tell patients, and this is true about OCD or any other thing, if you're going to be looking for someone to hire to help you with whatever the situation is, it is acceptable and appropriate to ask them questions in terms of what training do you have in teaching OCD? How long have you been doing it? How many patients have you had? Tell me the specifics about your knowledge related to treating this particular disorder.
Mhm.
And so my question to you as a professional is, if somebody were to ask you those questions, do you get offended or do you appreciate it?
No, I I clearly love talking about this. So I have given that advice to clients of mine who are going to a psychiatrist, for example. You're interviewing them, they work for you. You are hiring them, like you pointed out, Andrew. So ask as many questions as you need to for you to feel comfortable going into this process. Because if you're going in with uncertainty or doubts about the person themselves, their qualifications, um, it's going to really hinder your ability to trust in them, trust in the process. So I would welcome any questions that people have about what it looks like, my training, anything like that. And even if they didn't ask, that's still the same information I would be providing in those first few sessions anyway, because it is so important for them to feel comfortable in the process, to understand it, and to know that the person they're working with knows what they're talking about. And so definitely ask all those questions to ensure that you're working with someone who is going to be best suited to help you.
Great, great. Well, I appreciate that. So, all right. Well, then, as we wrap up here, Nick, I want to thank you for taking the time out of your day to share your experiences with the audience.
Mhm.
Certainly, if you're an audience member and you have questions or concerns, things that you think Nick could help you with, absolutely reach out to him. He has my endorsement. I know his work,
Thank
and
you,
I know
Andrew.
he does a good job. So thank you all for watching. Thanks for joining us, Nick, and perhaps we'll have you back again in the future to talk about some expanded opportunities later on. So we appreciate you.
Sounds good. Thank you so much, Andrew. I appreciate it.